Welcome to the Research Works podcast, live from the European Academy of Childhood Disability Conference 2024 in Bruges, Belgium. Join us for interviews with keynote speakers, world-renowned researchers and clinicians, and behind-the-scenes stories from one of the great paediatric conferences in the world.
All right, well, we have another wonderful guest here. We have Deepti Chugh from the Great Ormond Street Hospital for Children in the UK. Welcome to the podcast.
Thank you so much. Thanks for inviting me.
Oh, it's lovely, lovely, lovely to have you here today. And look, when I saw what your poster was on, it was very obvious that I had to speak with you. So your poster is on what outcomes within domains of the ICF are reported after selective dorsal rhizotomy procedure for ambulant children and young people with cerebral palsy, a scope and review of the last 3 decades.
Yes, that's right. It's quite a mouthful title.
No small thing, but it tells me a lot about what you really looked into for this. So before we really get into the details and the nuts and bolts of all of it, how about you give us a bit of an overview snapshot about what it is that you have in this poster?
So as the title suggests, I was quite interested in looking at what outcomes have been evaluated or investigated in this population. I have been very interested in this, in SDR, selective dorsal rhizotomy, and just wanted to get an overview of what have we reporting. Has it changed over the last 3 decades?
Yes.
And I wanted to use ICF as a framework and to map these outcomes along that framework to see if there were any gaps in the reporting of the outcomes at all.
Yeah, no, that's really, really good. So I think what's really useful to go into, because I mean, I love the ICF as a framework. It helps us to really conceptualize what things mean. It gives it some order. Let's talk a little bit about SDR in the first place. I know SDR is a neurosurgical intervention, but often when parents might look it up or clinicians look it up, it can be really wide ranging in terms of what it can do, which is what we'll talk about. But let's go into what SDR even is in the first place.
So selective dorsal rhizotomy, most commonly known as SDR, it's a neurosurgical procedure, and it is one of the treatments for management of spasticity, which is stiffness in the body or muscles. Yeah. And it is a permanent treatment and it is irreversible, where some of the sensory nerve roots are cut through surgical procedure. Yeah. And it leads to reduction in spasticity in the legs. And mainly it's used for lower limbs in children who have bilateral cerebral palsy.
Yeah, sure. It's a very specific population, really,
It is very specific population, and it is for a very selective group within that population as well.
True. And look, I remember working in the clinics when we were looking at the best candidates for SDR. So you mentioned there already that, spasticity has to be the primary problem. What about if a child presents of dystonia? Is SDR indicated for them, or is it mostly just spasticity, not dystonia?
Most of these children do have a component of dystonia, or they have mixed tone. Okay. It's very rare to see pure spasticity. Yeah. We are not talking about a primary dystonia here. It's the secondary dystonia, which like how the signals are sent, how the wiring is in the brain. And so, but we have to, when we are selecting patients, we are looking for children who are primarily presenting with spasticity. Yes. Spasticity is the predominant factor and not the dystonia. Yeah. So some element of dystonia is acceptable, but it shouldn't be the main feature.
Yeah, sure. I think that's always really important to talk about because, these interventions are very specific for a very specific reason. So I guess now we can go into the details of what you found in your scoping review. Now, that's a lot of papers to review, I suppose. What did you include in your review?
So I was interested in ambulatory children, children who are able to walk with or without walking aids. Okay. So how we would classify as GMFCS level 1, 2, and 3, because that's my primary interest. And most of the literature within SDR is in that domain. Yeah. And I wanted to look at different what's been done. And eligibility criteria was quite broad because there are different surgical procedures, different techniques that's been used across the world. So I was quite open to it. It doesn't matter which technique they have used because the main purpose is to reduce spasticity surgically. Yes. So I found quite a lot of papers, did search across 6 databases, didn't want to miss out on any publications. And in the end, ended up with 174 papers, which fit this criteria. Wow. So that was quite a lot.
That's quite a decent number, really. So the 162 papers that met the inclusion criteria. That's a lot of papers. So within that, then tell us a little bit more about what you found once you had gone through all of those 162.
So most of the outcomes were reported in the body structure function domain.
Interesting.
Of the ICF. So that was about 100 and I would say 90% of the literature was focused in body function and structure.
Yeah.
And then it was followed by activity and participation.
Okay.
And when I looked across 3 decades, there wasn't much change in the reporting of. You would assume that as there is much more influence on, there is much more talk about activity and participation in cerebral palsy, that things would change a little bit.
Yeah.
But it still remained consistent across 3 decades when I looked at the proportion of papers reporting on these domains, on these outcomes.
Interesting. So in the body structure and function domain, what were some of the main areas that people really reported on?
I mean, spasticity being one of the main ones.
Goodness me, I hope so.
Because that's what it addresses. So spasticity, modified Ashworth scale was mainly used, and that would be that was the primary outcome.
Right.
And then it was followed by joint range of motion.
Okay.
And gait analysis. So those were the 3. And within activity domain, it was gross motor function measure.
Okay.
And for participation, activity/participation, it was PEDI or PEDI-CAD, which is Pediatric Evaluation of Disability Inventory.
That's really interesting, isn't it? And within the body structure and function and the gait analysis, what kind of gait analysis was done? Was it mostly observational? Was there 3D or what sort of things people look at?
So it was mainly either 2D or 3D. Because studies that were in the first decade it was mainly 2-dimensional gait analysis. And then as technology moved on, it was 3-dimensional gait analysis. Okay. There have been few studies looking at observational gait analysis using Edinburgh Visual Gait, but they were in minority. So that wasn't...
So everything sounds like very clinically based kind of assessments, not too, I guess, researchy in a way. So very clinically based. So when it came to body structure and function and those outcome measures, what did they say? I mean, was SDR looking like it was effective on that level?
This particular scoping review wasn't looking at the effectiveness. It was mainly looking at a broad overview of what has been used to capture.
Sure.
But from my own experience, clinical experience, yes, SDR is effective in reducing spasticity.
Yes. Yeah.
But the influence on other domains, on activity and participation in the longer term is still debatable.
Yeah.
So that's where we are.
That makes sense as well, though, doesn't it? When we talk about specificity of an intervention, this is a spasticity reducing intervention.
Of course.
So it has that effect. But if you want to have an influence on motor function, you might have some improvements because there's less spasticity. But I imagine you also need to work on those motor skills to improve that. They're not in isolation, I suppose.
Yeah, they're definitely not in isolation. And although I'm saying SDR, most of these studies did include intensive. It was followed by a period of intensive rehabilitation.
Okay.
That comes as a part and parcel of selective dorsal rhizotomy treatment that children need to undergo intensive rehab for at least up to 2 years so that they can gain, as you pointed out, they can get benefit of that in gross motor function or activities and strengthen.
Yeah, and I guess from your experience as a clinician as well, this forms part of that, I guess, inclusion criteria for an SDI is that the family and the child has the capacity to do that kind of intensive therapy afterwards.
Definitely. It's definitely one of the criteria, how motivated they are, whether they can cope with that intensity of rehabilitation. And we often advise that even before they go for this surgical procedure, they have a stint of try it out for 6 weeks. How does it feel?
Yeah.
And it's not just about doing rehab from the child's perspective. It's also from the family's perspective, what it looks like taking the child to a rehab center or having that. Yeah. And it's quite financially as well. It's quite a resource intensive.
Absolutely.
Time and money both.
Yeah, absolutely. So I guess from this scoping review then, what are you hoping that this will have an impact on, I guess, the reasons why you did it in the first place.
Yeah, as I said earlier, that I wanted to look at if there were any gaps, whether we were reporting on other domains like activity, participation, quality of life, because that's why we are doing this surgery. It's not just to reduce spasticity, but to see how it affects children's lives or families' lives.
Yeah.
So what I found was that there were very few children-reported outcomes, that it was mainly proxy, parents reported. Sure. It was driven by parents, which is understandable because of the age group that when the surgery happens. Yeah. But at the same time, we felt that we need to have children's and families' perspective on what it means, like or families who have undergone this procedure, have gone through the process. What do they think about it? Because sometimes they come with changes that none of our standardized outcome measures can even evaluate or can capture. Yeah. So what my take-home message would be to involve families, ask them, and use some different methodologies, because most of these studies have been quantitative, using quantitative research methods. Sure. So I just found one qualitative piece of work. And so it is quite interesting because we are doing this to children and families and we are not even asking them what it means for them.
Well, you've raised a really important point there, because it's absolutely true, isn't it? This is a life-changing, it's permanent, irreversible, requires a lot of intensive work from everyone involved, resource intensive, like you said. And for over 90% of the outcomes to be body structure and function, which is, a relatively small part of someone's life. There's a whole lot of activity and participation and life out there. We really do want to know what that looks like. So I think this really points the direction of where the gap is. And I think you found the gap.
Definitely.
It's definitely quite a gap. And, the qualitative methodology too, like, look, I feel like in the last few episodes of speaking to people at this conference already, we've really been highlighting that we really need good outcome measures that can really pick up on the actual changes and the specific area that we want to focus on. Because without them, we can't really appreciate the impact these interventions might have on families.
I would totally agree.
There's a lot of work needs to happen on that. I used to think outcome measures, developing outcome measures was not for me. It wasn't like an area of research of interest, but now everything underpinning that is a good outcome measure.
Yeah.
So hopefully from here, the call out is for clinicians and researchers to look at the qualitative, conduct a qualitative interview and have that lived experience to inform future practice and future potential candidates.
Definitely.
Yeah. Wonderful work. So thank you so much for sharing that with us today and for talking to us about this poster. It's just so important to talk about different areas of interventions that we might think we know a lot about, but when you actually do a scope and review of the last 3 decades, we actually have a little bit more room to grow here.
Yes, I would agree. And it's very like when you see it on paper, you know about it. Yes. But it's something else when you see it on paper, what it looks like.
Well done on doing the work. Doing a scope and review is no small thing. Any review is no small thing. So congratulations on that. And,
thank you.
And to all of our listeners, I hope you really enjoyed that as well today. Do stay tuned. There'll be more episodes headed your way, but I'll talk to you all again really soon. Bye.
Thank you.